Okay, so welcome everyone, and thank you for joining us today for Osteoporosis Canada's webinar on medications and osteoporosis. Top 5 things to know with our guest panelist, Dr. Teri Charrois. We hope you're all keeping well during this time, and thanks again for joining us today. My name is Liz Kehler, and I'm the Community Engagement Coordinator for Osteoporosis Canada in the Alberta and BC region, and I will be your host and moderator today. We would like to begin by acknowledging that we are on traditional territories in Alberta of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries, and to those persons of whom we share this great land with today. So a few points before we get started. So we will have a short Q&A period following the presentation. To submit a question during the webinar, please use the Q&A feature located on the menu bar at the bottom of your screen. And we will answer as many questions as possible during this live webinar within the time available. And this presentation will provide general information about bone health and osteoporosis and is not intended as individualized health or medical advice. For specific individual health questions, please consult with your healthcare provider. So a bit about Osteoporosis Canada. So OC educates, empowers, and supports individuals and communities in the risk reduction and treatment of osteoporosis and osteoporotic fractures to help improve bone health and quality of life. Our Scientific Advisory Council, also known as SAC, is made up of experts in osteoporosis and bone metabolism, and they advise on scientific and medical issues and ensure that our information is current and based on up-to-date research. As a voluntary organization, we also have hundreds of volunteers across the country, many of whom are living with osteoporosis, volunteering to educate people about bone health and osteoporosis. So who we serve. So while osteoporosis can affect people almost any age, it is most common among Canadians 50 years of age and older. 2 million Canadians are affected by osteoporosis, and at least 1 in 3 women and 1 in 5 men will break a bone due to osteoporosis in their lifetime. Over 80% of all fractures in people 50 plus are caused by osteoporosis. And fractures from osteoporosis are more common than heart attack, stroke, and breast cancer combined. So with the natural concerns that come with osteoporosis, it's important to find out what you can do. Today, with a variety of treatments and appropriate lifestyle changes, individuals can prevent or slow bone loss and reduce the risk of fractures and go on to live full, active lives. Which brings us all here today. So I'm pleased to introduce our guest panelist, Teri Charrois. Teri is currently the Clinical Associate Professor and Director of Practice Innovation in the Faculty of Pharmacy and Pharmaceutical Sciences at the University of Alberta, and recently completed her Doctor of Education from the University of Calgary. For her clinical practice, Teri works in a multidisciplinary osteoporosis clinic once a week in the Division of Rheumatology at the University of Alberta. So thank you, Teri, for joining us. I now turn it over to you.
Thank you very much, Liz. Welcome, everybody. I'm excited to be here today to talk to you about the 5 top things we think you should know about medications and osteoporosis. So as Liz mentioned, I am a pharmacist with the Northern Alberta Osteoporosis Program, and I see patients with osteoporosis every week in our multidisciplinary clinic. Next slide, Liz. So these are based on the common questions we see in our clinic, and that's how I developed this talk for today. So the top 5 things we get asked about specifically with regards to medications are how do the medications actually work on our bones and our bone health? How patients should take their medications to make sure they're working as best as possible. What are the most concerning side effects? What other medications can actually affect or worsen your bone health? And what medications might put you at risk of falls? And we're always worried about that, as that increases your risk of having a fracture. So we'll cover all of these things in this talk today. Next slide, Liz. All right, so our first discussion is going to be around how osteoporosis medications actually work. If you could advance the slide. So our bones normally are always building new bone and taking away old bone. And we call this process remodeling. And this is how our bones stay as strong as they possibly can. And what happens is in osteoporosis, this remodeling process gets unbalanced. So there's an unbalance between building of bone and taking away of old bone. And that's how osteoporosis develops. So all of our medications we use work on this process. So the building of new bone with osteoclasts and the taking away, or sorry, osteoblasts and the taking away of old bone with osteoclasts. Those words don't matter here or there if you can remember just building new bone and taking away old bone. Advance, please. So we have really 3 categories of medications that we use for osteoporosis, and I'm sure for many of you these names are familiar. So we have the medications that slow bone removal. So that includes the bisphosphonates, and that includes denosumab. So those bisphosphonates are Fosamax or Actonel, as well as Aclasta, which is given intravenously. And then denosumab is also known as Prolia. Then the next category of medications we have build new bone. So they actually work on bone building. And the one medication we have in that category is teriparatide or Forteo. And finally, we have a brand new category of medications, and it's called romosozumab or Evenity, which is much easier to say. And the Evenity actually both slows bone removal as well as building new bone. Next. So no matter how the medications work, if they build new bone or prevent bone loss, our goal with all of them is to prevent fractures. And that's all of these medications have been shown to prevent vertebral and hip fractures, which are the 2 most common fractures associated with osteoporosis. Next, please. There are other medications that can be used. I'm not going to cover them in detail, but in women who are postmenopausal, hormone replacement therapy can be used for osteoporosis, and that's estrogen, sometimes with or without progesterone, as well as something called raloxifene. Generally, hormone replacement therapy with estrogen is used in postmenopausal women who are having symptoms related to menopause, and we sort of save that for those cases. So the other thing is with raloxifene, we only have data on it preventing vertebral fractures, not hip fractures. So again, we keep that in mind when we're choosing our medications. Next. And core to all of this is ensuring adequate calcium and vitamin D. So calcium for patients who are over 50, for anybody actually who's over 50, if they have osteoporosis or otherwise, we recommend 1,200 milligrams of calcium a day. We always prefer calcium from food as opposed to supplementation. So calcium tablets you can get at your pharmacy. So calcium-rich foods are definitely preferred. And if you have any questions about that, we do have a calcium calculator on Osteoporosis Canada website. I'll show you that in a minute. And also you can always discuss it with a registered dietitian who can help you select foods that are calcium rich, because it's more than just having an extra glass of milk a day. The other key part to all of this is adequate vitamin D intake, and especially in Canada, where in the winter we don't see the sunlight as much, we could be deficient or low in our vitamin D. So we always recommend 200 to 1,000 units a day of vitamin D if you're over 50. And it's hard to get enough vitamin D from our diet, so we often recommend supplementation in that case. Next slide. This is an example, so this is just a screenshot of the Osteoporosis Canada calcium calculator and what you get in the end. So you log into the calculator, it asks you a few questions, how old you are, if you're male or female, and then you input some information about your diet, and then it tells you how much you should increase your calcium intake. So this is an example for a woman who's over 50, and she was taking some yogurt a day, like one serving of yogurt, a little bit of cheese, and some beans every day, because beans can have some calcium in it. And it still showed that she was about 500 milligrams short of calcium. And then you can look on the website as well. There's information to how to increase your calcium intake or talk to a registered dietitian. Next. All right, so next we're going to talk about the medication. If you have been prescribed a medication, how you should ideally take that medication. Next. So the most common group of drugs we use for osteoporosis management is something called bisphosphonate, sorry, just technical issue on my end here. A group of medications called bisphosphonates, and these are usually taken once a week, usually. So always refer to the information on your prescription vial. And when we take these medications, we generally recommend to our patients who come to clinic that they take them first thing in the morning, 1 day a week. So pick whatever day of the week works for you. Often people pick a weekend because it's less busy. They get up, they take their bisphosphonate right away, and then they wait at least 30 minutes to eat. When they take that bisphosphonate, so that Fosamax or Actonel, they take it with a full glass of water, not glass of water as it says there on the slide, sorry. And do not lie down after you take it because it can have some effect on your throat. We recommend always taking it on the same day of the week. But if you forget 1 week, don't take 2 the next week. If you forget by a day or 2, it's okay to catch up, but never take 2 on the same day. There are 2 formulations that are exceptions to this. So Actonel DR is a formulation, and it is actually supposed to be taken with food, and it will say that clearly. It should say that clearly on your prescription label. And then there's also an Actonel that you actually only take once a month, and that's a slightly higher dose. Next. Zoledronic acid is also a bisphosphonate, so it's known as Eclasta, and it's actually given intravenously once a year. So usually you have to go into a specialized clinic or an outpatient center to get this medication, and it's given over about 15 minutes in an IV bag, and then that's it, once a year and you're done. Every province has different coverage, and I'm not going to go into that. So some provinces cover this drug and other provinces don't. Next slide. So we have a few other injectable medications, but these aren't intravenous infusions. So these ones that are injected just under the skin. And so one of those is denosumab, and it is injected under the skin every 6 months. So you get 1 injection every 6 months. That's Prolia. Next is teriparatide, or Forteo, and it's injected under the skin, but it's injected daily. So generally with denosumab, the Prolia, which is once every 6 months, you can see your doctor, or in some provinces you can see your pharmacist and they can give that to you because it's only once every 6 months. But with teriparatide, because it's every day, you need to learn how to administer that to yourself. With teriparatide, it's only given for 2 years total time. That's what we have safety information on. That's starting to potentially change, but for right now, it's still a 2-year course. And then the newest drug, Evenity, or romosozumab, is injected under the skin once a month. The difference with this is you actually have to get 2 needles every month because it's quite a large volume that has to go under your skin, and it doesn't fit in one spot. So you get 2 injections once every month, and you can take that medication for up to a year. Next slide, please. With all of this, it's really important to try and take your medications on time as prescribed and try not to be late with any doses. And this is particularly important with Prolia or denosumab. So if you're getting it every 6 months, try and put a reminder in your phone or write it on a calendar or whatever works for you to remember to get that every 6 months. With all of them, we want you to ensure an adequate intake of both calcium and vitamin D. And if your prescriber has provided you with a lab requisition that you need to get lab work done, it needs to be done when recommended with regards to the medications. Next. All right, we're going to talk about side effects because this is one of the big concerns we always have from our patients. Next. So these are the side effects I'm going to go through on this slide are just common side effects. So we see these most commonly, and they're generally not concerning. Most of them will go away after time. However, if these side effects become so bothersome to you that you can't manage them, this is when you would go back to see your physician or whoever prescribed the medication for you and discuss with alternatives, but never stop these medications on their own. So with the oral bisphosphonates, so again, the Fosamax and Actonel, they often cause some stomach upset. So nausea and diarrhea, a bit of stomach pain we see very often. It can go away with time. Patients often complain about joint and muscle pain, but again, seems to go away with time. With denosumab or Prolia, the once every 6 month injection, patients find that they feel sort of unwell, kind of like they have a little bit of the flu right around the dose, but it goes away usually within a day or two. And again, you can get some muscle and joint pain with that one. With Forteo, that's everyday injection. Again, some stomach upset, some dizziness, and also we find it can cause some leg cramps. And with the newest drug, Evenity, again, joint and muscle pain, we see a common theme there, and it also has a higher incidence of headaches. Next. So these side effects I'm going to talk about are the ones we get more concerned about, and they're a bit riskier is how we consider them. So with both oral bisphosphonates and with denosumab or Prolia, they can cause a decreased blood flow to the jaw. So this is seen generally when these drugs are given at a higher dose for a longer period of time. And this is something we always recommend that you discuss with your dentist if you're getting considerable amount of dental work done, to let them know that you're on one of these medications. The other concerning thing with oral bisphosphonates and denosumab is something we call an atypical femoral fracture. So it's an unusual break in your thigh bones, that bone of your thigh. And it shows up often as a sharp pain at the very, very top of your thigh. And if you have a sharp pain and you're on one of these medications at the top of your thigh, that pain comes, we recommend you go to Emerge or see your family physician or your prescriber as soon as you can, because it could mean that there's a fracture there. Teriparatide or Forteo, the one thing we worry about is really high calcium levels, and that can be shown as either severe constipation or muscle weakness. And that's why we recommend that if you have a requisition to get lab work done with any of these medications, you get that done so your healthcare provider can track all of these things like your calcium levels. The last medication, romosozumab, again, can cause that decreased blood flow to the jaw. So you need to talk to your dentist if you're getting significant dental work. That unusual fracture of the thigh bone or atypical femoral fracture. And it also was found in some of the early studies to have some heart effects. And so we're always very cautious with these medications if you've had a history of a heart attack or a stroke. And again, that's something you should discuss with your prescriber. Next. All right, there's also medications that you can be taking for other medical conditions you have that can actually affect your bone health. So I'm going to give you an overview of what those medications are and how we manage that. Next. This is a list. There are others that have been found to affect bone health. These are the most common ones. So the most common one by far away, the one we worry about the most, is glucocorticoids. They're often called steroid pills or prednisone. And these ones, without a doubt, significantly can affect your bone health. And I'll talk about them a bit more. Prostate cancer and breast cancer medications can as well, and that's why we often follow patients who have prostate and breast cancer quite closely with regards to their bone health. Some medications that patients use for epilepsy or just for seizures can affect your bone health. There are some stomach medications. They're often called PPIs or proton pump inhibitors. Depo-Provera, which is an injectable oral contraceptive, sorry, an injectable contraception, and it can decrease bone health. If your thyroid medication dose hasn't been checked and the dose is too high for your system, as well as some water pills or diuretics for blood pressure. Next slide. So as I said, glucocorticoids or prednisone drugs increase your risk no matter what. We know across the board, they increase your risk of fractures and decreased bone mineral density. That risk gets worse the longer you're on it and the higher the dose you're on. And we generally really are concerned about doses greater than 7.5 milligrams a day for over 3 months. And if somebody is on doses like that, we often will put them on preventative medication. So we might put them on an osteoporosis medication, even though they don't actually have osteoporosis. But again, that's individualized for that particular person. We know that prednisone and glucocorticoids both decrease your bone mass, so the weight or the strength of your bone, as well as increasing your risk of fractures. In terms of breast cancer and prostate cancer medications, they can both cause bone loss because it has an effect on your hormone balance in your body, and they've been shown to increase fracture risk. And these patients often get a bone mineral density test at the beginning of treatment, so that can be followed along to make sure we see if there's any significant bone loss while they're on these medications. So we follow it that way. Next. So heartburn medications or stomach medications called proton pump inhibitors. They seem to affect our calcium absorption in our stomach, so we often recommend different calcium supplements. If a patient's on a calcium supplement with a proton pump inhibitor, we recommend generally calcium citrate instead of calcium carbonate to help with that absorption in the stomach. And we know that they increase risk of fractures. Again, don't stop without consulting your prescriber, but it is something that should be reassessed frequently. So Depo-Provera is an injectable contraception device that women use, and it's been on the market for quite a number of years, and we're now seeing that it has been shown in people who have used it at a younger age that it decreases their bone density. It does seem to be reversible once it's stopped. Next. So thyroid medications in general, if they're followed appropriately and your dose is adjusted based on your thyroid blood tests, it's never a problem. So it's just if you've been given too much for a period of time. Again, with seizure medications, it's something that we just follow and see how patients are doing. Most of these seizure medications affect bone health by affecting vitamin D in your body. So we always make sure these patients are taking an adequate amount of vitamin D. And then finally, diuretics, which are used for high blood pressure. So they're also known as water pills often, and they make you pee out calcium from your kidneys. So we always want to make sure that those patients are having enough calcium intake. But again, we never stop these medications because they're obviously needed for other health conditions. We just have to manage and follow and keep a close eye. Next. So again, I've said this a few times and I'll say it again, but never stop any of your medications without consulting your physician or your pharmacist, making sure that everything is in balance. Ensuring that you're following the recommendations for calcium and vitamin D intake. And if you've been told to take a little bit more vitamin D, depending on what medications you are, to follow that as well. And always making sure you're getting any blood tests that you're recommended. So for example, with the thyroid pills, we want to make sure your thyroid gets tested routinely and making sure you're staying on top of all of that. I know it's a bit challenging sometimes, especially right now with COVID, to get a blood test, but we try and make it as least often as we possibly can. Next. So finally, the final question I'll go through is what medications can actually increase your risk of falls? And as we talked about in the beginning, and as Liz mentioned, it's really your risk of falls. So 1 in 3 women and 1 in 5 men, when they get older, have the risk of having a fracture due to osteoporosis. So it's something we're really concerned about. And so we want to minimize your risk of falls while also giving you appropriate medications to make sure your bones are as strong as they can be. Next. So if you are on medications for your blood pressure, they can often cause some dizziness. So we call it postural hypotension. So you'll find if you're getting up from sitting after a while, you might feel a bit sort of dizzy or woozy after you stand up. And that's because your blood pressure drops significantly from sitting to standing. So it's always a good idea, especially if you're getting up in the morning and you've been lying down for a long time, to sort of sit up from your bed, shake your feet out a little bit at the side of the bed, give yourself a minute before you stand up. The other thing you can do on your own is to monitor your blood pressure at home and make sure it's not too low either, because that's when we start worrying about it. So if you're having sort of that dizziness and you're monitoring your blood pressure, it's something you can talk to your doctor about. Opioid medications or pain medications or narcotic pain medications can cause some dizziness, and they can make people feel a bit woozy as well and cause that sort of change in balance. And as long as you're using it as recommended by your doctor, you should be fine. But just again, keep in mind that it can cause some dizziness and wooziness, and if need be, to make sure you're being safe in your house so as not to fall. Sleeping pills can cause dizziness and balance changes. So again, only take as prescribed. And when you get up in the morning, there can be a little bit of what we call a hangover effect. So you can still feel quite drowsy in the morning, and that can increase your risk of falls. So always be careful, again, getting out of bed, making sure you sit at the edge of the bed and shake your feet a bit. Next. We also know that the more medications a patient is on, the higher the risk of falls. So it's just the sheer volume of medications and how they may interact with each other. So it's good to get your complete list of medications, so everything you're on, reviewed by your doctor or pharmacist at least once a year. And that's called a medication review. And it's a good way to just make sure everything is still needed and if any adjustments can be made at this time. And never stop taking your prescribed medications without consulting someone first. The other key part to helping limit your risk of falls is strength and balance training. And if you go to the next slide, Liz, I can show you one of our key things. We use this in our clinic all the time, and it's available on the Osteoporosis Canada website. And it's called the Too Fit to Fall or Fracture handout. And you can go, this is just a screen grab of it, but there's a lot of other recommendations on that two-handed sheet as well. But it gives you some ideas for safe strength training as well as safe balance exercises. So like I said, we give this to almost every one of our patients we see in clinic. Next. So just in general, it's always good to remember that medications are only one part of your osteoporosis management. So there's some lifestyle factors that you should consider as well. So we know that smoking can affect your bone health. So if you're at the place where you think you can consider stopping smoking, to talk to your doctor or pharmacist about that. We know excessive alcohol intake can increase your risk of fractures. So that's also always something we check with our patients about. And then also making sure you have adequate calcium and vitamin D. So those are all what we call modifiable risk factors. So risk factors we can do something about. There are certain risk factors we can't do something about. You have a higher risk of having osteoporosis if you're female, and unfortunately that's not something, you know, that changes over time. As well, your risk just increases with age, and again, not a risk factor we can modify. But doing what we can to those modifiable risk factors helps with your overall osteoporosis management. It's always good to take your medications, obviously, as prescribed by your physician or whatever prescriber you're seeing. Avoid skipping doses where possible and trying to take them at the same time every day or once a week, depending on the medication you're on. If you do have specific questions about your medications, to talk to your doctor or your pharmacist, and never stop a prescribed medication before checking with them as well. So just, I know I've said that a number of times, but that's really key, because the advice I'm giving here today is just general health medication related advice, and every person's case is different and every consideration for a patient is different. Next. All right, so I think Liz will come back on and we're going to talk about some questions and answers we're getting in. I see them flying through on the Q&A here.
Yeah. All right. Well, thanks so much, Teri. That was a very thorough presentation. Yeah, so we do have quite a few questions here. First of all, before we start, I just want to thank everyone that submitted questions in advance and also during the webinar. So I will go ahead and moderate our Q&A, and let's start with this first question. Sorry, I'm just, okay. So at what stage of osteoporosis, at what stage of osteoporosis are medications and treatments prescribed?
Yeah, so what we do when we're considering starting somebody on an osteoporosis medication is we do what we call a risk assessment. So there's a couple different calculators or tools we use to figure out a patient's risk of having a fracture in the next 10 years. So there's low risk, there's moderate risk, and then there's high risk. And included in that calculation is your bone mineral density, so your T score, and then your other risk factors. So that can include if you've had a fracture before, a fragility fracture specifically, your family history, alcohol, smoking, age, etc. And based on that risk assessment, we decide whether or not you should be started on medications. So if you're in the low category, we don't start medications usually. If you're in the moderate category, that's the maybe. And then if you're high risk, we generally start medication. So it's very much dependent on your bone mineral density and your other risk factors.
Great, thank you. So the next question that we have is, if I start a medication, can I ever stop it once started?
Yeah, so this is a common question. So the question comes up as, am I going to have to be on this medication for life? So some patients will and some people won't. So it's really dependent on a number of factors. And it's again dependent on that risk factor category that you fall into. If you're in that moderate category, often we may treat for a few years and then stop. If you're in the high risk category, we often continue it long term. We do assess in our clinic, we see our patients once a year at minimum, and we assess every year whether continued need for that medication exists. So do they still need to be on that medication? And then we consider what's called the drug holiday, sort of around about 5 years, usually. Now that means some patients will come off in 5 years, and that means that some patients won't, again, depending on that risk category.
Great, thank you, Teri. So let's go on to another question. So can medication reverse osteoporosis?
Yes, so the short answer is no. Some of the newer agents, so Forteo and Evenity, so that's teriparatide and romosozumab, they're what we call anabolic. Those are the ones that can build some bone. So they do build bone, but we don't see enough increase in bone mass to actually fully reverse osteoporosis. Bisphosphonates generally don't, and Prolia don't build bone, but it can maintain where you are, so it can stop that progression. So one of the pharmacists in our clinic talked about it as Prolia and bisphosphonates work as your brakes as you're going down a hill. So if you're in a car and you're going down the hill, Prolia is the brakes to make sure that that car isn't going down the hill too quickly. So your bone mass isn't dropping that quickly. But generally, it isn't truly considered reversible, but we can stop the process and stop it from getting worse.
Great, thank you. So our next question we'll ask is, how long can you stay on Prolia and or other medication or treatments?
Yeah, and I saw this lots of Prolia questions coming through, and I think that's because of the concern of when you stop Prolia, there's an immediate increase in your risk of having vertebral fractures. So it's something we worry about, and that's why we always make sure with Prolia you're getting it every 6 months and you're not missing a dose. So with Prolia, you can stop it and it can be fine. What happens is once you stop it, you go back to your baseline bone mineral density very quickly. So if your baseline bone mineral density isn't too bad, we can treat you for a few years and then stop it, and it will just revert back to that baseline. It's not going to make it worse, but you'll never sort of, it does reverse quite quickly. So in patients who were worried about their baseline bone mineral density being quite low, we may transition them from Prolia to another medication after, but it's very dependent, again, on the specific situation. So we always have other options for these patients if we have to stop Prolia. It's not starting Prolia doesn't mean you have to be on it forever, but there are considerations we have to take keep in mind and make sure, again, that we're assessing it sort of at that every year mark.
Okay, and let's take maybe a couple more questions. Let's see, is Evenity available as an oral medication?
No, Evenity is not available as an oral medication. The problem with actually all of these medications is they just don't get absorbed into our body very well. And so when we take them orally, they just get eaten up by our stomach acid. So Evenity can only be given by injection.
Great, thank you. And I did notice we had some questions just about the presentation today. And I just want to say that it is being recorded, and we will have it on our OC replay later on, or it will be emailed to you when it's available. So that was one other question, and maybe let's just take one last question here. Well, you mentioned drug vacation already.
Yeah, I see one here that I can easily answer quick, and then you can pick one while I'm answering this. So it says, how does someone decide whether to prescribe a medication that slows bone loss, builds a new bone, or a drug that does both? So unfortunately, a lot of our decisions are based on what's covered for patients. So most provinces require you to start with a bisphosphonate first. I know that's how it is in Alberta. And the other thing with all of these medications is we know right now they all seem to work fairly similarly, whether they build bone or stop bone loss. So it's not like one is way better than another. So we do generally start with bisphosphonates, and then depending on patient's response, we can go from there. With teriparatide, which is the one that builds new bones, it's about, at least in Alberta, $20,000 a year. So it's clearly not something we start in most of our patients, and it's not covered by our provincial drug plan. So we have to keep all of those considerations in mind as well. But if you get started on bisphosphonates, which slow bone loss, it's a great starting choice. It works for most patients, and it will help reduce your risk of both hip and vertebral fractures. Did you find another one there, Liz?
Well, there are so many here. I think most of them are ones that you've answered already.
Okay.
That are quite similar. We seem to be getting similar questions.
I see lots of questions about calcium and vitamin D as well. So refer to the website. There are different recommendations based on age as well, but in general, once you're over 50, you're going to be taking 1,200 milligrams of calcium a day and 800 to 2,000 of vitamin D. But Osteoporosis Canada has some great information on both of those, calcium and vitamin D.
Yes, there is. Oh, and I guess one question about bone mineral density test.
Yep.
And I'm not sure if you can answer, but how often should someone get a BMD test?
Yep. So we recommend in most of our patients 2 years. That's what our government pays for. Our government doesn't pay for less than 2 years, except if you're on high dose prednisone. So in patients on high dose prednisone, we may do that once a year, but you can even have it every 3 to 5 years and that's fine as well. You don't have to get it every 2 years.
Okay, great. Okay, and I think there's quite a few questions still coming in, and pretty much the common questions that you've answered. So I think we'll end it there. And also we do have lots of resources available on our website. So that we'll go ahead and go to our next slide here. Sorry, I'm just going to.
I'm seeing a few. Yeah, as I'm scrolling through,
okay.
It just lots of questions about which medication is better, and I think I've sort of touched on that, but we generally do start with bisphosphonates because they work really, really, really well, and then when we move to the other agents are far more expensive, so we reserve them generally, but we also don't have good data to show that one of them is so much better than the other one. So that's really also guiding our choices as well. All right, I'll let you move on, Liz.
Okay.
I could lose myself in these questions.
Yeah, there is quite a bit. And I think, I think most of them have been addressed for the most part. So we'll go ahead and. Okay, so. So again, I just want to thank everyone again for the questions. Sorry, just bear with me 1 second. I'm just trying to get my next slide here. And are we at the more info?
Yeah.
For more info?
Yeah.
Okay, thank you. All right. Yeah, so thank you again, Teri, for answering these questions. And I hope that this has provided you all valuable information, as well to perhaps even help start the conversation with your healthcare provider to assess which is best for you. So before we conclude this webinar, please visit our website for links to the calcium calculator, easy way to calculate your daily calcium intake that Teri had mentioned. And also we have some great recipes for bone building nutrients, including calcium and protein. And we also have the Know Your Risk quiz, so please go ahead and share that. And as I mentioned, you can visit the OC Replay webpage, which will have the recorded version of this webinar today. And I believe there will be an email sent as well, just as a reminder. And also, please go ahead and visit our website. And before you go, I just want to thank you, Teri, again for your time today and sharing your expertise with us. Again, for more information and to stay connected, please visit our website at osteoporosis.ca or our social media. And thank you all again for joining us. Take care and have a great day.
Thank you.
Thank you.